What's up, everybody? Welcome to Mostly True Psychiatry with me, Dr. Mellon. Today is Neuroleptic Malignant Syndrome, or as it's given in the parlance of psychiatry, NMS. We're going to go over the overview, diagnosis, and treatment. First, baseline knowledge checking. I've got a couple questions. Just wanted you to think about it. I'll give you a second, see if you can answer. So, what are the three important cardinal features of NMS? They're supposed to be present 95% of the time, all three. So each of them is present 95% of the time or more. All right, that's hopefully enough time. So the things you're always looking for is it's fever, rigidity, and profuse sweating. And it's generalized rigidity, not just like their arms stiff or just their face and they have an oculogyric crisis or something. Generalized rigidity, fever, which is from partially presumed to be from that, and you're incredibly sweaty when you're rigid. So what is the mechanism of action of the drugs that can cause NMS? Two examples would be haloperidol and metoclopramide. Levodopa would be another one. I'll give you a second. That is correct. They affect dopamine. It can actually be increasing dopamine or reducing dopamine. So antipsychotics, they're reducing the dopamine. They're dopamine antagonists. And then things like levodopa, when it gets caused Parkinson's disease, they're dopamine agonists, and it's that stopping it is what causes this for those folks. Why is it important to know the diagnosis and treatment of NMS despite being unlikely you will ever see this diagnosis in person? I'll give you a second to think about it. Or pause the video or whatever. All right. It's because this can actually kill people, right? This is one of those rare situations in psychiatry that can actually lead to the death of the patient. So, if you see one in your whole career, probably hedge on being a little more conservative and hopefully, get that person killed. All right. Can we treat these patients in an ED or inpatient psychiatry? Where do we treat these patients with NMS? If you try to do it inpatient, do not pass go. Do not collect $200. Do not kill your patient. They go to the ICU. So they're going to go from the ED and they're going to make their way to the ICU. Do not bring them to your floor. Okay. Next question. What is the most important differential diagnosis you should always consider when you think, hey, this might be NMS? What has to be the rule-out diagnosis? Serotonin syndrome, right? That's it. They can also be very rigid and sweaty, and it can be very similar in presentation on those aspects. All right. So this is what we're going to cover in this lecture. I'll do story time, kind of a real and fake patient example. So let's change that because it's not just real, it's real and fake patient example. Where the diagnosis fits in the DSM. DSM-5, being more specific. Hopefully it doesn't change in the new version that comes out next year. General information on NMS, how you make the diagnosis, what's the differential diagnosis, treatment, ongoing research things generally, comprehension check. We'll do a drug sheet, fact sheet, source documents at the end. We'll spend lots of time on those source documents. I know you love that stuff. So story time. This is a patient I had in the last year. So as a 50-year-old woman, came into the ER by parent, and the patient was severely rigid and severely distressed. Could speak, kind of brief things, kind of repetitive, just panic mode. Primary team reported recent inpatient discharge on haloperidol, and there was some mentionings of a long-acting injectable. The patient went to the ICU and psych was consulted. Went to the ICU. That's great. That's where this patient belongs. I was unable to get records from the inpatient hospital despite like 4 tries. It took about a solid week to get it. And it's from a big city, so it's not like, oh, they're just from that little place where Dr. Mellon's from. The patient wasn't able to communicate effectively during the interview for the first day or two. She was severely rigid over her entire body, locked. Her head was in a weird position, kind of hunched a little bit, tremoring. Her muscles were so tight. Eyes like way too much wide. I mean, she was panicking. Wanted help. Thought she was going to die. Thought it was never going to end. She couldn't swallow or take food at that point. And overall, a pretty clear sensorium at that time. So another kind of patient, this one's fake. This will just be your, what you're supposed to look for. You have a 40-year-old, 50-year-old, whatever, schizophrenic patient, patient with schizophrenia, I'm sorry. Recently had a change in antipsychotic medication over, 3, 4, 5 days. It's not in one day, over 3, 4, 5 days. Patient had worsening dystonia, difficulty moving, which is called akinesia. Temperature was increasing over the course of a day and began to have some confusions, change in sensorium, getting drowsy at times, agitated others, so kind of looking like a delirium. A day later, the patient's vital signs start to get irregular. You're breathing faster, your heart rate's getting a little variable, blood pressure is variable, starting to flush, incontinent, which actually the other patient was incontinent too. And then so it's kind of like a slow, gradual build and things get worse. Not in a day, though. It's over several days. So where does the diagnosis fit? So the big section of the DSM is this big blurb. It's medication-induced movement disorder and other adverse effects of medication. And these are the 10-ish, diagnoses that are in that section. And so neuroleptic malignant syndrome is within there. Tardive dyskinesia is in this section of the DSM as well, or medication-induced Parkinsonism. The general information on NMS, things you should know, kind of factoids. So as a kind of a thought process of what the definition is or what is NMS, it's an idiosyncratic. When I say that, I just mean give 500 people exact same med, do the exact same changes in meds on 500 people, and it just randomly occurs. Even the same person, same med, they go back on the same medication later, doesn't do it. It's an idiosyncratic, potentially fatal effect of dopaminergic agents. It can be increasing or decreasing. Like we said, levodopa, it's increasing, Parkinson's patient, or you're giving them, haloperidol and you're blocking dopamine. With rigidity, fever, diaphoresis, and subsequent multi-organ failure. Outcomes of treatment, what should you expect, right? Like realistically, you need to have a good idea in your head. If you catch it early, typically it's less than 2 weeks. Not the same day, not 3 days. I know everybody wants it to get fixed all of a sudden. Typically within whatever the word is for weeks in Spanish, in 2 weeks. Otherwise, if it's not caught super early, maybe it's already gone on for 4 or 5 days when you get in there. Maybe it lasts a month, right? Before they kind of get back to baseline, still have a little bit of rigidity or something at that point. So it's just not a fast fix. You can't just walk in, oculogyric crisis patient, stab them with Benadryl 50, walk out, and they're fantastic 30 minutes later. It's not that kind of thing. The outcomes of treatment, most people kind of say 10 to 20% range now because we kind of recognize it, we look for it, we have ICUs, we have standard better ways of keeping people alive when they have autonomic dysfunction or electrolyte disturbances and that kind of thing. Before it was recognized very well, it was roughly a 30% death rate, so like every third patient died when this happened. And it's super rare. 1 in 10,000 patients treated with antipsychotics. That's the estimation. 1 in 10,000. So if you treat 200 new people with 200 people with antipsychotics a year for 50 years, you may see one. So you will misdiagnose this multiple times during your career, like I did recently with that first patient. It was not NMS, but I didn't have any of the information to, in all fairness. It took a couple days to figure it out. So this is a little bit of a zebra, right? It's an important zebra because there's only a few, murdering zebras that can cause terrible things to happen in psychiatry, but this is one of them. So overdiagnose it, do your best. But really, you gotta look for those cardinal symptoms, right? You need fever, diaphoresis, rigidity. Risk factors. These are all fake. DSM lists them and stuff. When you look at research, they say they have no idea because if something's happening 1 in 10,000 times, it's a handful of times in the U.S. per year. They're not all like tightly linked in research, so we don't know. Basically, starting or changing doses of dopamine blocking, or actually of dopaminergic agents, right? We said it's either way. Dopaminergic agents. They say that using multiple antipsychotics is a risk factor. So there's another reason to push back whenever they're trying to give, aripiprazole plus, Haldol to somebody or something. The drugs reported to cause NMS. So they have a bunch of case studies. So they've done it with all the antipsychotics, first, second, third kind of idea. None of them are exempt. It can be dopaminergic withdrawal situations like levodopa. These notes are crazy at times. I will fix them as we go. It's lithium. I don't know how well that one, to be honest, is done because they used to think lithium plus Haldol caused this, and then they decided no, lithium absolutely did not cause it when added to Haldol. The TCAs have been reported. Contrast agents, diatrizoate, or however you pronounce that, is one. Antiemetics, there's the classic ones that affect dopamine, and then some VMAT drugs like reserpine. So general information continued. The theory of the NMS etiology. I hate these words, but I try to use them so that you get them. Let's look smart for a second. So the etiology means the set of causes, or manner of causation of a disease. So, what causes it, right? Etiology. Sounds good in medicine. So some of the theories: blocking dopamine in the nigrostriatum, I guess. Right, that's kind of wrong wording. Causes rigidity, tremor, which is, I don't know if that's correct or not. We'll see. Should be nigrostriatum, one word. Causes rigidity, tremor, whenever you give people Parkinsonism by giving them too much medications, right, with too much antipsychotics, rather. Alternative, if the dopamine antagonism leads to a destabilization of the autonomic nervous system muscle tone, that's another theory. It's a completely different one. Blocking dopamine in the hypothalamus provides a theoretical cause for basic hyperthermia, because the hypothalamus is where you regulate body temperature, so maybe something to do with dopamine there. Adrenal increases are noted in the urine and plasma catecholamine. It's not worth checking for. It's there. I guess if you're really not sure about the diagnosis, it's fine. And it increases during NMS, so you maybe that has something to do with causing autonomic instability, right? If you're starting to kind of dump norepinephrine, epinephrine, that kind of things periodically, or the abnormal amount that could cause blood pressure and things start to vary, and heart rate and respiratory rate. There's defects in calcium regulatory proteins in the sympathetic neurons is another kind of idea. The problems with the theories is basically they don't explain why it's so rare. None of the theories kind of explain all the issues of what it actually causes. There's a little bit of genetics, but it's just a real small number of like 2-3 kind of people studies or cases that have been found with familial runs, and it's those are people who probably have like weird calcium channel regulation or something realistically. Making the diagnosis. So the DSM does a terrible job in just laying it out and being nice and clear like it is for everything else. So this is partially from that, partially just from all the kind of other guidelines that have been put together recently for this situation. So they need to be taking a dopamine drug, right? So if you have any kind of real information on them and you know what medications are on, they have to be on a dopamine drug. If they're not, it's something else. Move on. You really want fever. You take the temperature twice orally if you can do it orally or whatever. But so it needs to be 2 separate measurements, and then it's considered hypothermia. If it's 40.5 on the first time you check it, I would recheck it that exact instant again, do a different route, do whatever you got to do. No, right then, and, because you're going to need to move forward quickly in that situation. There's a little bit of genetics, but it's just a real small number of there's a lot of So they get profusely sweaty, and that's basically NMS looks at that way. Malignant catatonia looks that way. You have generalized rigidity. They're not going to be responsive to like levodopa and stuff or anti-Parkinson's agents, and it's not like their arm, not their head. Generalized rigidity. The motor symptoms are all to do with kind of stiff and shaky. Okay, so tremor, akinesia, difficulty initiating movement, dystonia, myoclonus, so they can just kind of be shaking. That's what that woman when I saw her was. They have difficulties with swallowing and that kind of stuff. So they can get a change in mental status. That's anything from delirium, stupor, coma. It's just change. So delirium would include like agitation, that kind of thing. Autonomic nervous symptoms. So you're looking for vital sign changes. So they typically say tachycardia, 25% above baseline. I don't know what their baseline means when they come in with this problem, but I guess if you have historical records, or if you see the shift over a couple days, right? Blood pressure, when you have a 25% fluctuation above or changing of the systolic or diastolic blood pressure. Respiratory rate, 50% over where they're at. So if they're at 12, they go up to 18. That's significant. You don't have to just go, it's 20 respirations per minute. Don't care, move on. Realistically, the nurse didn't count it when it's 20, right? We all know that because it's just reality. Urinary incontinence can happen in pallor. So there are lab findings you can look for. So if you have rhabdo, you get an AKI, and with that acute kidney injury, you get metabolic acidosis, right? So electrolyte derangement. Their leukocytes can go increase up to about 40K, so pretty significant. CK typically 4 times upper normal limit at least, and then works its way up. You end up with myoglobinuria because you have to do with the blood and urine. You can check for catecholamines. Creatinine you're going to be following because they have an AKI. Iron will be low. To exclude it, you just basically need to make sure it's not due to another, neurological condition or medical condition or another mental disorder. And we'll get to the differentials, which are these 4 things you should look for every time. So what was the number 1 differential diagnosis you should look up? Catatonia. So catatonia spontaneously occurs in all mood disorders. Both catatonia and NMS are going to have rigidity, mutism, stupor. So not really responsive, right, and rigid. Catatonia, unlike NMS, will have significant symptom improvement with benzodiazepines. So when you give benzos, they just magically get a lot better. NMS, unlike catatonia, would be fever, myoglobinuria, AKI, autonomic nervous system dysfunction, and those kind of abnormal labs. Serotonin syndrome, that was the differential. I totally messed this up. That's hilarious. Let's move that on top. Serotonin syndrome is the one you should look for. Why didn't you guys all correct me on that last one? Probably screaming at your computer and I just can't hear you. Serotonin syndrome, that's the one you look for. So they both can have autonomic nervous system dysfunction, altered mental status, tremor, rigidity, elevated white blood cells can happen in serotonin syndrome. So most of the signs. Obvious drug difference, are they on a serotonin drug or are they on a dopamine drug? Worst case scenario, they're on both and it doesn't help you. A big thing is if you have any of the time frame pieces, serotonin syndrome is fast, like typically within a day. Neuroleptic Malignant syndrome occurs over several days, so it gets worse and worse and worse. So if you had this dramatic change in a day or a day and a half, 2 days, it's probably serotonin syndrome if you don't have any information. Another thing is serotonin syndrome has a lot of GI symptoms. You have nausea, vomiting, diarrhea. That doesn't happen in NMS. So if they're vomiting and diarrhea, probably go with serotonin syndrome. A medication-induced acute dystonia. That was that poor lady at the beginning, and that's why I got confused because I had no labs to support anything. It was just garbage at the beginning. Couldn't get the paperwork. So it was a patient that ended up had severe rigidity, freaking out, some tachycardia, some of those kind of things. But it was basically a long-acting injectable on top of orals, and the long-acting injectable was causing prolonged dystonia. And so I learned my lesson. You still didn't have the fever. It doesn't count. I mean, that fever should be there. Had severe rhabdo and everything from that dystonia. But so probably something to really pay attention to is there's more long-acting injectables now than there used to be, so this is probably going to be more of a thing in the future, is more likely situation. CNS infections, dysfunctions, like if you really don't have a lot to go on, a person has a big sore on their body or wound and they get all rigid and crazy, botulism or something weird, you can go for medical, strokes, hemorrhage, that kind of thing. Treatment, what do you do? So send them to the ICU. Everything's done in the ICU. It's just supportive therapy. Hydration, cooling, vital signs monitoring, trying to take care of kidney injuries, cardiac arrhythmias, electrolyte disturbances, all that stuff. There's no universally agreed upon treatment guidelines, and the APA, DSM things, they don't help you here very much. You need to figure out if it was due to an antipsychotic, you need to stop that antipsychotic right away. If it's due to withdrawal from that antipsychotic, you actually need to restart it. You got to get them back on the levodopa, because it's going to stay bad longer if you don't restart the levodopa. If it's so the first thing everybody does is basically they start lorazepam, because the initial symptoms kind of look like, basically, if we go back up for our differential, for the catatonia right here, they can look the same because it's a progressing thing over time. It's easy to make the diagnosis when they just present with everything, but when the person goes, I got belly pain and a little bit of shoulder pain, and then it takes you a week to figure out it's cancer, right? Referred pain type thing from the vagal nerve because of the weird pathway or whatever. Like they don't always present perfect to you. So we basically, a lot of people end up treating serotonin syndrome, catatonia, and the NMS simultaneously. So lorazepam, if it's catatonia, it'll get better. That'll help out. It probably helps with agitation the distress as well, anxiety. The typical 2 medication treatments given is dantrolene, which is a peripheral acting muscle relaxant. It's specifically trying to stop that severe rhabdo, right? It's going directly at that. Bromocriptine, which is a dopamine agonist that can reverse the hypodopaminergic state. So if it's a person was getting Haldol and they drop their dopamine and they all got locked up, you're giving the dopamine back to try to reduce the time frame to correction by the central nervous system. If you don't have that where you're at, amantadine is the alternative often used. There's no evidence one works better than the other kind of thing. Once treated, you should wait at least 2 weeks before you do an oral. So if there's severely, schizophrenic, it's uncontrolled, it's bad, you're still going to wait a couple weeks, even once everything looks okay and they're completely clear, before you're willing to restart an antipsychotic on them again. And remember, I said that this is a completely randomly occurring thing. It's idiopathic on when it starts. So you're not expecting them to give them a new one, they're going to lock up again. They'll probably never. It's 1 in 50,000. Having it once doesn't mean it's going to happen again. So I kind of like the guidelines that were done fairly recently by this German group. They basically just looked at all the guidelines on the planet, and then in 4 or 5 languages, because they're all bosses and can speak multiple languages, unlike us. So I looked at a bunch of articles and all the review systems, and they just said which ones show up all the time as the same treatment strategies across the planet. So they gave a 5-step thing. So if it's drug-induced Parkinsonism, they're just kind of rigid and tremor right now, then you're just going to go ahead and reduce or switch that antipsychotic or anticholinergic that caused it. If it's a drug-induced catatonia, then you have rigidity, mutism, but now you have stupor and other symptoms of catatonia, which I've already done a lecture on. And then you also are going to switch that antipsychotic or stop it or reduce it. And you give lorazepam, most typically, diazepam alternative, and you just treat it and it breaks magically, or you have to go to ECT. And then you get into NMS. So these are the dangerous, kind of like mild, moderate, severe, or it could be like early symptoms after a couple days, and then symptoms once it's full-blown NMS or whatever. So it's just a basic escalation process. I'll do the diagnosis escalation and then the treatment escalation. You just look at this chart later. So the diagnosis is they're basically always going to a change in their rigidity. So it goes from like mildly kind of stiff, rigid, tremorous, to maybe as far as catatonia, altered mental status. The rigidity gets more and more severe to where when you have, quote, severe NMS, there it's like lead pipe rigidity, right? Like the person is locked. So we'll put that right here. So it's like lead pipe. This is where that term would actually come into play and mean something. They use heart rate just escalating as a sign. So they say less than 100, up to 120, and then over 120 when you get to severe. Temperature slowly goes up, so basically just mild fever. It's it's under 100.4, and then it's to a normal severe. So I guess 100.4 is actually the cutoff for fever. So afebrile would be mild. 38 to 40 degrees Celsius, so pretty reasonable fever setup is when you're at moderate. And then basically a severe NMS at 40 degrees Celsius, you're reaching hypothermia issues where your body's going to stop being able to regulate body temperature at that point. It just goes up because you lose your thermostat, just like you do for hypothermia, right? So you discontinue the antipsychotics, you start lorazepam, you send them to the ICU, you start bromocriptine, so we haven't done dantrolene, you do bromocriptine first, and you're just trying at the mild to moderate, or at the moderate level, you're just trying to see if you can get them to where they're start having better ability to move, less stiff, autonomic instability kind of cuts down. Once it's severe, you're going to also start giving them dantrolene. Dantrolene's not to be taken lightly because it's also, with the dosing we're going to do, it's hepatotoxic. And then if you can't get it fixed with severe NMS within, 2 days, if everything's just bad, not getting any better, even worsening, you really got to start lining up ECT at that point. It's considered the more definitive treatment. So this is like the actual dosing kind of ideas. So lorazepam, you can start 1 milligram Q6 or 2 milligrams Q4 kind of thing. 8 milligrams a day is going to be your max, and it's a common part of treatment for this. It's low quality of evidence. It's basically just treating that kind of catatonia-like symptoms. Despite low quality of evidence, every guideline basically still shoves it on there. Bromocriptine, if it's not too bad and you just want to see how it goes, you start 2.5 milligrams 3 times a day. Otherwise, you go 15 milligrams 3 times a day. And this is trying to reverse that low dopamine state. You're going to continue it for 10 days if it was oral antipsychotics that caused this, or 3 weeks if it was a IM. Realistically, it depends on the IM because those are changing over time. It might be 4 or 5 or 6 weeks at some point if we're the longer acting ones. 30 milligrams typical upper dose. There was at least one that went all the way up to 60. If you don't have that, you go to amantadine. For the bromocriptine, do it for a day or two, see how things are, and you can go from 2.5 and you go up to 5 or something, right? And just see how things are going. Let you move something around, see if it's helping. Amantadine is your alternative. It's an IV drug too, which is nice. So you don't have to shove a tube in their nose and toss it in because they can have dysphagia and you don't want to choke them, and get like pneumonia from it or whatever, aspirate it. Dantrolene, pretty big range. Basically, you start at 1 milligram per kilogram Q6 kind of thing. So it's 4 times a day for 2 days. And you can increase that up towards 2.5 if you need to. So this is for rhabdo. It is hepatotoxic. You only give it if there's like fever and rigid, like 102, then they're rigid, that kind of thing. Don't do this step lightly. And you actually have to kind of taper it off 50 to 200. You have to subtract 50 to 200 milligrams a day until you get them off. And if those don't work, you got to go to ECT. Don't kill your patient. All right, let's see if anything I said stuck. How do you actually measure their fever? Like what do you look at, or what is a reasonable guideline for that on how you measure fever for NMS? Initially, it's oral, and you need to do it twice. Don't take one temperature reading. One temperature reading, just ignore it. You can ask for a repeat, right? So how quickly do you expect them to recover? Right, you are treating a patient, they're in the ICU, general medicine team's like, they're jumping all over you, trying to make things better and better and better. How long is it going to take to actually get better? That's right, your job's to calm everybody down. It's even if things go well, it might take a week or two. If things go bad, maybe it takes 4 weeks. What medication is given to treat the rhabdomyolysis from NMS? You'll disappoint me if you miss this one. That's right, dantrolene. Dantrolene. So we're going to jump back up just so you can see it again. It's a weird word. This is a peripheral muscle relaxant. All right. What do you do if the patient is receiving dantrolene and bromocriptine for 2 or 3 days and everything still sucks? They're getting worse. You're scared. The general medicine team is scared. What do you do? You are going to send them to ECT. This stuff's not working. You got to go to the next step. You don't want to, have your one NMS patient your entire life and you kill them. What do you do different if NMS is caused by stopping levodopa and Parkinson's disease patient? Let's pause for a second if you need to. You restart it, okay? So don't just think, antipsychotics can't have it or dopamine drugs can't do it. If it caused it, you got to give it back. Assessment and plan. This is for kind of a live presentation so people can have this PowerPoint and cut and paste this, but I'll just leave it at that. This is actually a text block you can use as a starting point for your notes. So it's bonus fact time. What does that damn word neuroleptic mean, right? Like, what is that weird thing? So antipsychotics were originally called neuroleptics. They weren't called antipsychotics originally. Neurolepsis was the term used to describe the effects of antipsychotics. It's what patients nowadays called zombie-like. I was zombie-like. So neurolepsis are the symptoms of the antipsychotics. They said reduced motor activity, decreased anxiety, and a generalized indifference to the external environment. Wasn't psychiatry grand back in the day? The efficacy of neuroleptics was thought to be related to them causing the EPS symptoms. And I'll do another history thing at some point on EPS and that weird term. The dose of which antipsychotics induce neurolepsis was called the neuroleptic threshold. So you gave Haldol and you increased the dose until you reached the neuroleptic threshold when you caused extrapyramidal symptoms. This dose was where an antipsychotic, then there's also like the neuroleptic threshold is the therapeutic dose, is another way of saying it back in the day. This idea became fundamentally challenged with the creation of clozapine, which was an atypical antipsychotic because it was effective in treating psychosis and did not reach the neuroleptic threshold. So there's a couple other sources, but I'm lazy, so these were kind of like the big ones I used when I built this. I hope that was helpful, and I'll see you next time. Cheers.